very early. And this type of bleeding is included into Figo Palm Cohen classification for AUD. We won't go in detail of that. Slides, no, I don't know why they're stick. They're not going ahead. Only now few slides are there, I think. I will stop sharing the screen. Yeah, let me just see whether I can just again share and see. Otherwise, I will just talk without the slides.
Ma'am, you can stop sharing and reshare it again.
Yeah, that's what I'm doing, but it's, yeah, now it is moving.
Yeah. Sometimes because of the network, it can happen.
Okay, so after menopause, the woman is very prone to develop hypertension, diabetes because of the insulin resistance and also atherosclerotic changes. So we had to be careful and we had to assess the woman accordingly. Even bone loss will start occurring very fast after menopause. You can see it here that in women and in men, the bone loss is occurring after 30 as it is, it goes down and drastically goes down after menopause in women. And they are silent sufferers usually because they are worried. They don't want to tell the doctor or they feel very shy. But the doctor, as a doctor, it is our duty to find out from them that whether they are suffering and how much they are suffering and then offer help to them. I'm sure the next speaker who is going to talk about the different hormonal therapies which will help the women. Now we say that not HRT, but we now say it is menopausal hormonal therapy. So I'm sure that with all these problems which I have discussed, we know that women do suffer. They do suffer in silence and they require help from the gynecologist to come out of these postmenopausal issues. And that is the, I think, next speaker who is going to talk about the different therapies which can help these women come out of these different issues which I have already discussed. I once again would like to thank Navi Mumbai Obstetric Gynec Society for inviting me for this webinar. Thank you very much.
Thank you. Thank you very much, ma'am, for being a part of our webinar. It was a delight listening to your talk. Any questions anyone would like to raise? To Ashwini, ma'am.
It was, I think, a basic topic. So I don't think that many questions will be there. This was just to, go through again that what different problems can occur in menopause. We all are aware of it. We just wanted to brush that knowledge so that now we are now ready to listen to the different hormonal therapies.
Yes, ma'am. Thank you. Thank you so much, ma'am. Moving on to the next session now. Dear members, give some 2 minutes. Okay. Let's start with our next session. For the next session, we would like to welcome Dr. Tejal Lathia, ma'am. Ma'am will give us a perspective on the endocrinal part of menopausal symptom management, and the topic for the session will be menopause through endocrinal lens. Dr. Tejal Lathia, ma'am, is an honorary consultant endocrinology at Apollo Hospitals, Navi Mumbai. She is the co-author of Language Matters for People Living with Type 2 Diabetes in India, co-designer for PCO program, convener Wellness and Women monthly endocrine webinar series. She has multiple publications in her name on various topics of endocrinology. Welcome, Tejal, ma'am. Welcome to the webinar.
Thank you. And I'll just quickly share my slides. I apologize in advance if my presentation is not what you were looking for, because Dr. Gandhi was saying that I'm going to talk about the different menopausal hormonal therapies, but I'm not really going to talk about exactly that. So just a little bit of variation on what I am supposed to talk about. Just one sec. Yeah. Hi, please just let me know if my slides are visible and I am also audible clearly.
Yes, ma'am. Your slides are visible and you're audible.
Okay. So because the topic was menopause through the endocrine lens, so I've kind of interpreted the topic a little bit. I spoke to one of my very dear friends, her gynecologist. Maybe she doesn't want me to tell you her name, but so I asked her, what exactly is it that you would like to know as a gynecologist? And also the problems which I face in my menopausal women sometimes who I see, and then I'll take it from there. So the first thing that I want to put out there and just publicly acknowledge is that there's very limited training in menopause management in endocrinology as well as gynecology. All the management of menopause I've learned has been after I finished my DM training. I've come out into clinical practice and then reading, updating my knowledge, and that's how I've improved my knowledge of menopause. I also talk about gynecology also. The reason being that recently we conducted a focus group discussion, and Shaliga knows about this, where one of the doctors actually spoke of how very little focus is on menopause during MD gynecology training. And that is why often people are not very confident about approaching menopause. Yes, the local vulvovaginal atrophy, those local things, it's easy to manage, but otherwise it's a challenge not only for endocrinologists but for gynecologists as well. So this is how I'm going to talk about my slide in 3 different sections. So the first section is common endocrine conditions intersecting with menopause. We'll talk about the current state of evidence and recommendations for, I'm sorry, Dr. Gandhi, I should have made it MHT, menopausal hormonal therapy. And also, this was the request of my friend, that also tell us medications which we can give without thinking so much about screening for breast cancer, cardiovascular disease, but which are effective in women who are going through the menopausal change. So I'm quickly going to do a case-based discussion. So the first is a 47-year-old lady who visits you for irregular periods. And often irregular periods, the ladies come to me as well, but if they come to a gynecologist, and this woman complains of severe muscle pains, joint pains, and muscle weakness. And as you're talking to her, she just comes up with this history that, you know what, I also have this recurrent kidney calculi problem, and I'm seeing a urologist for it, but somehow they just keep coming again and again. So what do you do in this patient? Do you treat her for her irregular periods and give her calcium and vitamin D? Or is there something else that you would like to do for this patient? Would anybody like to take the question? That is there anything else that would cross your mind in a woman who is in the perimenopausal age range? She has severe muscle pains and joint pains, and she incidentally talks about kidney stones. So if anybody wants to attempt it, they could just unmute their mic. But Dr. Sangeeta Srivastav is here. So she recently referred me a patient like this.
Yeah, ma'am. We would like to check her calcium, vitamin D levels.
Excellent, ma'am. Thank you very much for talking about this. So yes, one of the conditions that you have to think about. So see, vitamin D, ma'am, we all think about, because, and it's almost ubiquitous that the family physician, the GP, the general physician, the endocrinologist, everybody is writing these patients vitamin D. But if there is a history of renal calculi along with muscle pain and weakness, then yes, we should consider hyperparathyroidism, where basically the body produces extra PTH, leading to high calcium levels. The other sequelae can be a lot of bone pains, fractures, and in very severe cases, can have cardiomyopathy, depression, brown tumors, and severe osteoporosis. I just got a perimenopausal woman who has medullary nephrocalcinosis, several non-obstructing renal calculi, and she has primary hyperparathyroidism. And one Dr. Srivastav is recently referred, who also seems to fit the bill. Now, the reason I put this slide is just to highlight that more than 80% of the patients in Western countries are asymptomatic. And a simple serum calcium, like Dr. Gude said, is an extremely easy and simple way to make sure that you're not putting calcium and vitamin D unnecessarily for patients who already have a high calcium level. Just do a simple serum calcium level. If it's high, then please refer to an endocrinologist. It's a very simple surgery. It's curative, and the patient's aches, pains, everything will go away, and the osteoporosis will also reverse. And as Dr. Gandhi was saying, that from the age of menopause, there's a rapid downhill in the bone mineral density. And if we are able to arrest hyperpara at this stage of a woman's life, then you really will prevent fractures in future. The second case is a 48-year-old lady. She has heavy bleeding during menses since the past 1 year. It's an erratic cycle. Kabhi 2 mahine mein aata hai, kabhi 15 din mein aata hai. Her TSH is 6.7. She doesn't have a goiter. She doesn't have a family history of thyroid disease. She does complain a recent bit of weight gain, mainly in the abdominal and the hip area. Otherwise, she feels bloated and swollen. What would you do for this patient? One is, would you treat this patient with thyroid medications because obviously the high TSH is causing all the problems? Would you do a thyroid antibody test, or would you consider repeating the test after 8 weeks and then thinking about what to do? Or of course, the fourth option is you could refer to an endocrinologist to ask whether treatment is needed or not. Would anybody like to answer this? Anyone? Or would you treat, not treat? What would you do? Okay, nobody wants to take this? Dr. Bharti, yes, yes, ma'am, please.
Yeah, can I? Yeah, she's a 48-year woman and she complains of menorrhagia. The first thing is to stop her bleeding, and you'd run a battery of investigations like a CBC, ESR, and her thyroid function test as is rightly done. TSH seems to be a little higher, so definitely we would like to start thyroxine. At the same time, see her hemoglobin and rule out any other hemoglobinopathies if they are there.
So yes, you will look at everything else, but would you straight away start thyroxine?
Yeah, if a TSH is high, definitely I would.
Okay, second question. So do you expect that by starting levothyroxine therapy, the bleeding will stop?
No, we have to give her other things also. We have to give her, like I would have given her PAUSE MF, some iron and B complex also. Or if it doesn't stop with PAUSE, then I have to give her progesterone.
Okay, so yeah, the gynec aspect, you guys are great. You don't need my help. Dr. Manisha?
I would like to repeat after 8 weeks.
Yeah,
nice.
Yeah, of course. I would also repeat after 8 weeks, definitely.
But with treatment,
I would not start on thyroid supplements right away. I would repeat after 8 weeks.
No, it is better.
No. I would start.
Okay. So I'm going to help you with that because that's why you called me here today, right?
Yeah.
Okay. Yeah. So let me explain. So why are we talking about this at all? It's the easiest thing in the world to start a woman on levothyroxine, right? But what we don't understand is that one step you take at the age of 48 pretty much is a life sentence for the patient. She has the burden of a chronic condition for the rest of her life. For the next 20, 30 years, she's going to have to take a medication which has been started with one single TSH value. Most of the times, there is no relief in the bleeding and no loss of weight at all, especially in a perimenopausal women. The reason I say this so confidently is because after they've been to all of you, when they don't lose weight, they come and eat my brains. Ki hamara vajan kam nahi hua, humne thyroid ka goli to kha liya. So let me tell you what you can do. So this is an Indian study, which in very short, I wanted to highlight. What they did is they divided patients into mild, moderate, and severe hypothyroidism. Now, mild hypothyroidism is a TSH between 5 and 10. Now, in patients with mild hypothyroidism, it's actually a hypercoagulable state. And it is very unlikely that a perimenopausal woman having bleeding, erratic bleeding with menorrhagia, sometimes oligomenorrhea, is unlikely to be because of this mild TSH elevation. Now, starting the medicine for this mild TSH elevation, which may or may not help with the bleeding, but also sentencing the person to lifelong therapy, because thyroid doesn't work that you give it for 3 months and you stop the medicine. Once you start, then the report will remain normal only if you continue the therapy. Of course, in moderate to severe hypothyroidism, TSH level more than 10, 15, 20, 100% I agree with Dr. Bharti. And yes, I would put the patient on medications. But borderline TSH values, yes, definitely repeat after 6 to 8 weeks. You may get an antibody test done. And if the report is more than 10, then I would suggest initiating treatment. If it's in the gray zone, you are safe to wait and watch. Give all the other treatment that you would give. 99% of the time, everything will come back to normal just with your treatment without adding on a thyroid medication. So only a TSH more than 10 is likely to cause excessive bleeding. TSH less than 10 is usually associated with, in fact, a hypercoagulable state and oligomenorrhea. Repeat a TSH once, always before starting treatment to avoid unnecessary treatment, especially if TSH is between 5 and 10 and the T3, T4 is absolutely normal. Thank you so much for everybody participating so actively, and we want different opinions so that we can sort out what's the right way to go. So this third patient is a 52-year-old woman. She had a recent wrist fracture. She has a history of a surgical menopause at age 38. Unfortunately, both the ovaries had to go because of bad chocolate cysts, severe endometriosis. Unfortunately, she's received very intermittent, erratic hormonal therapy from the age of 38 up until about 42, where then she was told by somebody that you shouldn't take hormones, it's bad for you and it will cause problems. And because of her fear, she didn't take the medications at all. She's now come to you for vaginal discharge and itching. And what do you do for her? So do you do the usual thing, that is treat the vaginal discharge, and as I recently learned from Sukriti, do an HPV test, or or do you consider something else about the fact that she had menopause at age 38? She received very intermittent hormonal replacement therapy, and now she's almost like 14 years down the line. Would anybody like to answer? Dr. Surekha wants to answer, I think.
This could be just genitourinary syndrome, because she has not taken a proper treatment, erratic treatment of hormone replacement. This is
okay. Anything else?
A premature menopause or premature ovarian insufficiency, and probably a local. I mean, we have to investigate her. And,
did anything else about the history strike you? 52 years old, wrist fracture, erratic hormonal therapy, early menopause.
Could be a premature ovarian failure.
Yes, we know it's premature ovarian failure. There is no discussion about that.
No, is it a parathyroid hormone?
Okay, so in this case, I did the calcium level, it was normal. Vitamin D is normal, calcium is normal, everything is normal. Anything else would you consider? Dr.
Hello?
Manisha? Yeah, please go ahead.
Osteoporosis?
Yes, Dr. Sangeeta Srivastav, Dr. Jyoti Bobe, yes, definitely we will consider osteoporosis in this patient. The thing is that most of our patients, when they have early menopause, we do initiate them on hormone replacement therapy. Then some Tom, Dick and Harry will tell them, "Arey hormone mat lo, acha nahi hai, aisa nahi hai, wo nahi hai, aisa nahi hai," and they will stop the treatment. So because of this, these women are very prone to osteoporosis, and she has a wrist fracture. She's only 52 years old of age. So yes, definitely what we're going to consider is that there's a definite association between primary ovarian insufficiency and osteoporosis. This study has just been published in June of 2021, where they've looked at almost 12,000 women in the Canadian longitudinal study of aging. And what they find is that women in the POI group not only will report more self-reported osteoporosis, more likely to be on drugs used for osteoporosis. And what they found is that cigarette smoking is one which worsens the bone mineral density, while obesity and current hormone therapy use is protective and can actually prevent the osteoporosis in future. So if you have a woman who has had early menopause and she has a wrist fracture, you have to do a bone mineral density scan. You have to look for osteoporosis and treat her. So refer women with premature menopause to an endocrinologist if needed, because in a busy gynecological practice, to give time and explain the whole therapy, make sure that they continue to do it, is extremely challenging. My own relative was did some cancer screening at some cancer hospital, which was doing some discount. And the oncologist there told her that you shouldn't take hormone therapy because it will cause cancer. And this was a woman who had premature ovarian insufficiency at the age of 34. And she was an ideal candidate for giving hormone replacement therapy. Also, please note that tibolone, hormone replacement therapy, and SERMs alone are not recommended for the management of osteoporosis. So yes, you can use them in the premature ovarian insufficiency, but if the patient has documented osteoporosis, you have to give her either a bisphosphonate or something like that. So please don't think that HRT is a replacement for osteoporosis therapy. Okay, so the take home from the first part of the presentation is that think of hyperparathyroidism in women who have muscle pains, bone pains, renal calculi, or fractures. And you just need to do a simple serum calcium. If it's normal, you're safe. If it's high, then don't start calcium. Please don't start vitamin D, and please refer the patient. A TSH which is less than 10, especially in a perimenopausal women, is extremely unlikely to cause menorrhagia. It adds to the medication burden, may not really help with the situation. So my suggestion would be, so do all your local therapy, whatever you need to give the patient, recheck the TSH in maybe about 6 to 8 weeks. If it is still less than 10, I would still recommend not starting therapy, keeping in mind that once you start therapy, this is lifelong. Last but not the least, premature menopause has to be treated, and I can't say it often enough. In busy gynecological practice, it is extremely important, difficult to ensure that this happens. And so many of my friends refer patients to me with premature menopause, and we put them on treatment. Also, think of osteoporosis in women who've had early menopause, especially if they haven't taken hormone replacement therapy properly. If they've had a fracture, please investigate, please refer, and please use appropriate therapy. So this was my first part of the presentation. Now the next three cases are all real cases of women who have come to my clinic in the perimenopausal age range. So the first was a 43-year-old woman. She started complaining of episodes of chest discomfort, sweating, breathlessness. She would just get hot all over. Obviously, nowadays, everybody has a home BP machine. So when the patient is extremely distressed, they will take the BP, and the BP was 150/100. So what did they do? They went to a cardiologist. Cardiologist said, oh, she may have a cardiovascular disease, though she had no diabetes, no hypertension, nothing else predating it. And he didn't ask for a menstrual history. And the patient underwent a coronary angiography, ultimately found that the coronaries were normal, then was referred to somebody else who was, I'm sorry to say, a male endocrinologist, and then underwent an extensive workup for hyperthyroidism, pheochromocytoma, and Cushing's disease. All these tests must have cost the patient close to 50,000 rupees. All it needed was a careful history taking. It was just a perimenopausal syndrome that she was having. Her menstruation was already irregular, and what she needed was treatment for the menopause. This is again a real life patient. She's my mother-in-law's friend. She'd had a recent hysterectomy with a salpingo-oophorectomy about 3 months prior to the time that she saw me. She started fighting with her family members. She couldn't sleep all night. She had severe hot flashes. And one day she calls me and tells me, I'm sitting in an auto and going to Vashi Bridge and I'm going to commit suicide. The reason I'm highlighting this is often in busy OPDs, we don't have time to listen to patients. And, we just focus on the medical aspect, not understanding that menopause has much greater implications than just the vulvovaginal atrophy and genitourinary syndrome. The third patient, and I still remember this patient, I can tell you her name also. She was 52 years old and she was my regular patient for diabetes, very, very well managed, took everything perfectly. HbA1c was great. And one fine day, she just very quietly tells me, I feel really guilty because my husband wants to have intercourse. But the minute I have intercourse, I have such agonizing pain. And the worst part is that she didn't receive help from whoever she consulted. That's different. But she was feeling guilty that she wasn't able to have intercourse for her spouse and she was depriving him of intercourse. So this is three different patients with very severe menopausal problems which do attend our clinics. And what do we do for them? This is what we usually do. Again, this is input from my gynecology friends. So you manage the bleeding in most of the patients, do a pap smear and a mammography to make sure that there are no issues. Prescribe a local estrogen cream. If there's candidiasis, you will treat that. And then most of the time, what we do is write phytoestrogens, ask them to do yoga, meditation, exercise, divert the mind, take calcium, do a healthy diet. And this is what most of us have been doing, including me, until I got interested in menopause and actually really started thinking about it. There's a multitude of symptoms out there which we are just not addressing. Very bad hot flashes, low libido, low erratic mood. They're depressed. They're thinking negatively all the time. They just feel tired all the time. Some patients describe it, by the time it's 4 o'clock, it's like my battery is worn down. Body pains, joint pains, forgetfulness, depression. And these can be very serious issues for the patient. I also think that during training, we always think about the biomedical aspect of every condition. What should we do? What medicine to write? But what we also do not sometimes think about is the psychosocial aspect. So there was this one woman who told me, I can't go to the office anymore because the minute I sit in the office, I have such severe hot flashes that I have to leave the office and come back home. So it does have huge impact on quality of life for our patients. It's time to do more. And in a patient who has no comorbidities, it's completely safe. Please initiate menopausal hormonal therapy. We'll talk a little bit about that in the next few slides. However, if there are comorbidities, if it's somebody with diabetes, if it's somebody who has hypertension, please refer to an endocrinologist. We'll do a comprehensive evaluation. There are a lot of calculators available which can tell you about the cardiovascular risk of the patient. There are calculators available which tell us about the breast cancer risk of the patient. We can do a comprehensive assessment, and if the risk is low, then again in these patients, menopausal hormone therapy can be safely prescribed. So I think most of you have heard about the WHI study, which is called the Women's Health Initiative. It is probably the one study which has done the greatest disservice to women. So what happened is probably it was some man who one fine day thought that maybe if we give estrogen, then women will not have cardiovascular disease, because estrogen is supposed to be protective of the heart. So what they did is they had almost 27,000 women between the age range of 50 to 8. They divided them into two groups, and in one group they gave estrogen alone, and the other group they gave estrogen with MDPA. And what they wanted to look at, the primary endpoint was reduction in cardiovascular disease, and they wanted to look at the safety aspect, that giving MHT does not increase the risk of invasive breast cancer. So they wanted to look at reduction of CHT and increase in breast cancer. And they also looked at several other things like fractures and pulmonary embolism and whatnot. Now, this is what the study showed, and this study was published in 2001. So what it found is that it was amazing for vasomotor symptoms. It reduced hip fractures, so addressed osteoporosis, and actually reduced the incidence of new onset diabetes. But what it also did is increase the risk of coronary artery disease, increase the risk of invasive breast cancer, could increase the risk of stroke and pulmonary embolism, and other smaller things. So obviously with the first two, that is increase in coronary artery disease and invasive breast cancer, there was almost a 60% drop in prescriptions for menopausal hormonal therapy around the world, because now it was that if you give menopausal therapy, you will increase the risk of MI, or you will cause your patient to have breast cancer. But then, of course, as time passed by, people looked at the study outcomes again. They went back and did analysis again. And what they found is that many of these women in which this MHT was given, some were as old as 70 years of age. If you looked at the inclusion criteria, 50 to 80. They didn't bother if there were any vasomotor symptoms. It was not seen what was the age since menopause, what was the age of the woman, and they were initiated on MHT. So women were actually as old as 70 or 72 when the treatment was started. Many of them were more than 20 years post-menopause. Almost 50% of the women were smokers. So what I'm trying to say here is the group that they included was very prone to have an adverse outcome. This is not the patient population that we are looking to treat. The other problem was that this trial had used MDPA, and we all know that medroxyprogesterone acetate does have an adverse cardiovascular metabolic profile. And in most of the newer studies, MDPA is no longer used. So when they reanalyzed the data, if the woman was less than 60 years of age, or she was less than 10 years post-menopause, it was perfectly safe to give the therapy. If she was more than 60 and more than 10 years, then it requires discretion, collaborative approach with the patient, and a final decision. What they also did when the subgroup analysis is looked at those patients who took estrogen alone and estrogen with MDPA. And they found that in the estrogen alone arm, that means in women who didn't have a uterus and could be given estrogen alone, there was actually a reduction in the risk of invasive breast cancer as well as coronary artery disease. It was probably the MDPA which is the culprit and causing the adverse outcome. So that is why now we have better progesterones available, micronized progesterone. You can use dydrogesterone, and these can be safely used. So currently what we have is we have one particular preparation which is available, which has already done the thought process for you. I have started using for patients. I'm following them up. And just the fact that they have severe symptoms, somebody is listening to them and addressing it is a sense of great relief. So when we finally look at menopause through the endocrine lens, this is the Endocrine Society Clinical Practice Guidelines. It's very clear who not to give the treatment to. But when you look at the list of conditions, most of your patients will not have any of these conditions. And please remember that diabetes is not a contraindication. So either active breast cancer or past cancer, benign malignant estrogen sensitive conditions, undiagnosed genital bleeding, untreated endometrial hyperplasia, venous thromboembolic disease in the past or now, untreated hypertension, active liver disease, and PCT. These are the only absolute contraindications. There are some relative contraindications where you have to use with caution. And then in this case, if you are not sure, then I think it's a good idea to refer to somebody who would do a comprehensive assessment for you. This is the IBS calculator, which you can use to calculate the breast cancer risk for your patient. It takes into account everything: the age of menarche, age of menopause, hormone exposure, family history, everything, and gives you risk. So the risk at the right is actually my own risk for breast cancer, and my risk for breast cancer is actually less than that of the population. So the red line is my personal risk, and the blue line is the population risk. This is the Q-RISK-3 score, which we use for calculation of cardiovascular disease. And you get a number like this. It tells you what is the risk of this person having a heart event in the next 10 years. So this, I'm sorry, I put the example of a, but if this was one of our patients, the risk is 22%. And in this, we would not give menopausal hormonal therapy. But if the risk is low, less than 5%, you can safely give the hormonal therapy without worrying about CV risk. One slide I was requested by, again, my friend. So what are the non-hormonal therapies which in a busy gynecological clinic we can write without having to worry about whether the patient will do the pap smear, whether the patient will do the mammography. I don't know what the blood sugars are. The patient is not willing to go to an endocrinologist. I don't know what the blood pressure control is. She doesn't know about her family history. And there are so many other uncertain factors. So some of these non-hormonal therapies have very, very good effect in patients with severe vasomotor symptoms and should be considered. So these are the common ones we use. So pregabalin 75 milligram and gabapentin 300 milligram. This is an absolutely safe medication we freely use for patients with diabetic neuropathy, can be used. Escitalopram does wonders, reduces the hot flashes, gives good sleep. So these are SSRIs, escitalopram, sertraline, and fluoxetine, and also SNRIs like venlafaxine and duloxetine. If you're worried about getting medications which a psychiatrist use, then escitalopram 10 milligram is the simplest to use. Patient doesn't experience any side effects but has a lot of benefit usually. So this is one of my patients who I just consulted yesterday, and we had given her escitalopram 10 milligram. I think it's been about a month now since she's taking the therapy. And she must have consulted a minimum of at least 6 to 7 doctors. She repeatedly told everybody about all the problems she's having, but was not able to get a meaningful result anywhere. After the escitalopram, she's able to sleep well. The hot flashes are at minimum. But now, of course, her worry is that I will get addicted to escitalopram. So I had to explain to her that this is a mild antidepressant. She's not going to get addicted to it. It's not a sedative. And her symptoms are almost 80% better, even without any menopausal hormonal therapy. So if you're too busy, your patient is not compliant, you're worried, then at least you can give this as a stopgap measure for your patient. But with the a caveat that menopausal hormonal therapy is the most effective treatment, at least for the vasomotor symptoms. The benefits outweigh the risks in most women. So less than 60, less than 10 years of menopause, you can strongly consider MHT without any fear. Of course, you have to individualize the therapy, ask the patient's preference, look at the clinical situation. And of course, always make sure that the CV and breast cancer risk is not high. There are free online calculators available, which you can actually use. So this was a review we wrote on the interrelationship of menopause and type 2 diabetes. And what I just wanted to underline here is that this is a unique opportunity when a woman consults her doctor for vasomotor symptoms. This visit can be used to sensitize a woman about the need for screening herself for type 2 diabetes, about the increase in weight and adiposity, and how she can prevent the weight gain as well as the type 2 diabetes. Thank you so much.
Thank you, ma'am. Any questions for Tejal, ma'am?
Madam, what is the treatment for painful intercourse that you have not said?
Yeah, because that is what the gynecologists do, right? So that is usually not what we do. But yes, even in patients who have painful intercourse, use of lubricants and local estrogen is recommended. However, even if you're using local estrogen, you have to be, of course, be careful about the risk of breast cancer, as well as the risk of, mainly the risk of estrogen-sensitive tumors. I think that if the patient has severe painful intercourse, and if the situation is right, then giving systemic menopausal hormonal therapy is very effective. I'm sure that all gynecologists get frustrated because you guys write the local estrogen. It doesn't have much of an impact, and the patient is back. I think careful
अच्छा
evaluation
आधे
of
बेरे
the
देते हैं
individual case, you can consider systemic hormonal
सर
therapy.
सर सर
In this case, oral, if you have transdermal estrogen, that would of course be better. But unfortunately, the availability of transdermal estrogen in India is erratic. The other issue is because of humidity, often the patches tend to come out and they look like pimple. And that is why usually we avoid the not avoid, it's not available or maybe not effective. Then a short course of menopausal hormonal therapy, as short as even 6 to 8 months, will really help. I'm just going to quickly take the questions in the chat box. So do you recommend the use of combined oral contraceptives? So no, we don't, because the progesterone that we need has to be the most least metabolically adverse wala jo hota hai. So using Femiston is a no-brainer. You can use it. For insomnia, the escitalopram works really well. So Dr. Sudha, if your patient is more than 60 years of age, you can't give menopausal hormonal therapy. Escitalopram works really well for the sleep, for the hot flashes, for a lot of the things. No, escitalopram or the sertraline and all are not addictive medications. They do not fall into the hypnotic sedative category. These are mild antidepressants. The patient will not experience sedation. Are transdermal gels equally effective as oral MNT for hot flushes? No, they're not. So systemic estrogen therapy works much better for hot flashes. The local estrogen will not help with the hot flushes. Okay, Dr. Jyoti, I have no clue about Tibolone. I have never used it in my life, so I'm really sorry, but you will have to teach me about Tibolone and CA breast. Okay, Dr. Wadhwani wants to know, do we monitor estradiol levels? What I always find in endocrinology and anything related with hormones, ultimately what the patient experiences should be your baseline. If the patient feels better, it doesn't matter what the estradiol levels are. The patient is happy, you keep it as 1 milligram of estradiol. If the patient is not happy, then yes, you can increase the dose. Anyway, the dose we're using is very small, 1 milligram and 2 milligram. Dr. Sudha, no, you don't need to do any investigation before starting escitalopram. No renal test, no liver test, nothing. And not to worry. Dr. Mini, I will leave the Tibolone to you people because I don't know anything about it. So I'm not going to put my finger in it. Just pregabalin, escitalopram can be started if you're not sure about what to do. You're not sure about the CV risk, breast cancer risk. Look at the risk calculators. Maybe you can talk to an endocrinologist. You can talk about it together and then take a joint decision. Thank you so much, everyone. No diet. I'm sorry. There is no diet for menopause. Forgetfulness, the escitalopram helps a lot, Dr. Jyoti. Yes, menopausal symptoms can last even up to 15 years. I didn't put that slide, but up to 5% of women have postmenopausal symptoms even 15 years after stopping their menses. And the last question I'm going to take, the phytoestrogens do not work, because I know everybody writes it, but they don't work. The last question I want to take is for early menopause. So Dr. Gude, if the patient is less than 30 years of age, then yes, we will consider still a Turner mosaic and we will do a karyotype. Once the woman crosses 30, usually it is unlikely that there will be a Turner mosaic, but we would look for associated autoimmune conditions. So at least a thyroid function test would be useful for these patients. So I hope whoever asked me the question got their answer. Thank you so much, and I'll stop here.
Thank you, ma'am. That was a very rapid fire question answer session. Thank you so much. Moving on to the next session now. Next session will be a panel discussion. The topic for the panel discussion will be clinical dilemmas with menopause and its management. The moderator for the session will be Dr. Surekha Mude ma'am. Ma'am is a senior consultant at Mude Maternity and Gynac Hospital and Cloud9 Hospital, Vashi, Navi Mumbai. She was also the founding member of NMOGS and past president of NMOGS. On the panel with her today, we will have Dr. Bharti More ma'am. Bharti More ma'am is a consultant at Shakuntala Women's Hospital, Airoli, Mathadi Hospital, Koppal. She is also honorary teacher at Jizao Municipal Hospital, Airoli. She has been the past president of NMOGS. She has been the chairperson of Navi Mumbai Menopause Society. She has also been a committee member for various prestigious societies. Joining Dr. Bharti More will be Dr. Sarita Bhalerao, ma'am, on the panel. Ma'am is a consultant at Bridge Candy, Reliance, HNH, Saifi, Bhatia, Wadia Maternity Hospital. She is the president of MOGS. She has been the joint secretary FOXY, chairperson of West Zone RCOG, and has assumed many such important positions across organizations. Along with Sarita ma'am, there will be Ashwini Bhalerao ma'am and Tejal ma'am also on the panel. Over to Surekha ma'am for the panel.
Thank you, Rituja. Thank you so much. Well, I think after a rapid session of Dr. Tejal, and it was really very practical. I think this panel discussion is sort of a repetition. Let's start with basic things. Let's start with the slides. So, can I ask Bharati, what is the definition of menopause, which I think Dr. Ashwini Bhalerao has already said, but anything new in it and anything new in the premature ovarian insufficiency or anybody can answer? Bharati More, are you in?
It's cessation of ovarian function.
Yes, it's a cessation of ovarian function for more than 12 months, along with the depletion of the ovarian follicles. And the average age in India is about 49.4, while in West it is 51. And premature ovarian insufficiency is the cessation of menses below the age of 40 years, but those women who had a previous normal menstrual cycles and without any primary hypogonadism. The incidence is about, say, 0.1% below the age of 40 years. Below the age of 30 years, it is less than, it's about, it's 1% below 40, 0.1% below 30 years, and below the age of 20 years, it is 0.01%. So let's go to the cases. The first case.
Ma'am, can I just make one comment?
Sure.
So in women who have already undergone a hysterectomy, sometimes it is challenging to diagnose the menopause. So then an FSH value, 2 consecutive values more than 40 would be considered as menopause.
Okay. So
because in a woman without a
values, but how? So when do you repeat the FSH level? How often?
4 weeks apart. 4 weeks. So 2 values 4 weeks apart more than 40 would be diagnostic of menopause in women who don't have a uterus.
Okay, so let's start with the cases. These two are different, little different cases, but both of them are presenting with basically vasomotor symptoms. This is a 51-year-old businesswoman, and she is menopausal since more than about 14 months back. She had her last period. She has hot flashes, she had cold sweat, she has mood swings, also feeling tired, gaining weight, and the quality of life is impaired. Her uterus is intact. There is no other significant family history. The second case is almost similar, but this woman has her periods still going on, though they are a little irregular. And the gap between the 2 cycles has been increasing. She also has vasomotor symptoms. Now, how do you proceed? Anybody can take, Dr. Ashwini, Dr. Bharti. Dr. Bharti, where are you?
Yeah. Good evening, everybody. See, there are 2 different cases. The first one, I think, is 14 months. She's not got a menses. And the second one is getting intermittent menses. Am I right?
Yes.
Yeah. So the first one is definitely 1 year of menopause, 1 year of cessation of menses, and she falls as menopausal. and the second one is perimenopausal. So yeah, now I would not go in for a FSH in every patient. Clinically, she's giving all history of hot flushes and sweats. So depending on what is the requirement of the patient, what is her age, what are
So how
her
will you go
risk
along with
factors.
history and examination?
Yeah, first, of course, history, examination, her age, her weight, her BMI, her hip waist ratio, what is her waist circumference, and history of other comorbidities like whether she has diabetes or hypertension or associated cardiovascular comorbidities. Of course, a lipid profile, all our investigations will do where you see her lipid profile, a liver function, whether there's an history of any thromboembolism, all those histories you will take. And then whatever the basic investigations depend on what are a high-risk comorbidities associated.
Yes.
And then we should start with hormone replacement therapy.
Yes, I'm coming. What treatment do you want to start?
Because the uterus is intact, I would go ahead with estrogen progesterone with equine estrogen 0.625 and 2.5 of MPA.
So what's the gold standard for vasomotor symptoms? The treatment, gold standard treatment for the vasomotor symptoms?
You have to give estrogen replacement therapy. Yes. And because the uterus is there, you have to add a progesterone so that, the unopposed endometrial hyperplasia is avoided. And therefore, the
why
risk of
do we use a medroxyprogesterone acetate?
So
we start with estrogen and medroxyprogesterone acetate. But of course, if she has comorbidities, then I would go for drospirenol.
No, it's the medroxyprogesterone acetate which is the main culprit for even breast cancer. So we avoid them and we start with either micronized progesterone or we start with dydrogesterone.
Agreed. If she has no comorbidities, I would go ahead with MPA. If comorbidities are there, yes. What are you saying?
But ma'am, if better options are available, why would you use MPA at all?
Yes. So
yeah, agreed.
Basically,
agreed.
I think Tejal, your video has been stalled.
Sorry.
Can you hear all of us?
I can hear you.
Can you hear us?
Yes.
Okay. So basically, in the first.
Sorry for the interruption. The internet connection was slow.
Dr. Ashwini, do you want to add anything?
See, I understand that there will be always a debate that which estrogen you will start and which progesterone you will give. So I do agree that medroxyprogesterone acetate was sometimes blamed for whatever that WHI problems were there, like increase in CA breast. But I don't think that we can say that totally we stop conjugated estrogen. I will not say at all that, because whatever said and done, conjugated estrogen will give definite good result, definitely for vasomotor symptoms. So, and yes, we can give her medroxyprogesterone acetate also, that each and every patient, if you give for a very short time and in a very small dose and under supervision, I'm sure there are very less chances of developing any cancer, etc. And I do not recollect if Bharti said this or not, but I will take this opportunity because the woman is more than 50 years old to do her pap smear, to do USG pelvis, and also do mammography. Because sometimes what happens is that already she has some changes in the mammography, and we don't do mammography, we just start her on hormone replacement therapy. Maybe later on mammography is done down the line after 6 months, and then the patient feels that these changes are because of hormone replacement therapy. So please remember,
basically we always start
hormone replacement therapy. I will definitely ask for a mammography, because as it is, she is due for a mammography. It is not because we are starting hormone replacement therapy. 51-year-old patient is due for her mammography.
Yes, anyway, we have started with the investigations. We have added that. So we always start estrogen therapy after doing all the investigations.
Yeah, yeah.
So mammography, DEXA, everything is included in that.
Pap smear, everything.
Anything? Yeah. So what is the therapy you will start, Dr. Ashwini?
Yeah, I would like
In
to
case
start
she
with
is going for
because
hormonal therapy.
conjugated equine estrogen comes in 0.3 milligram also.
Yeah.
I would start with 0.3 milligram of that.
Yes.
And in the later half of the month, I will add medroxyprogesterone acetate or
10 to
dydrogesterone.
14.
Because nowadays, this conjugated estrogen doesn't come into a combined pill. So we have to add progesterone separately into the tablet. Means we have to tell the patient that the last 15 days of the month, she will add progesterone into it. And or if you want to give continuous therapy, she can take continuously estrogen plus continuous progesterone. So there is no withdrawal bleeding. So
Yes,
it
so we
depends on
always-
what type of a bleeding she wants. If she says,
Yes.
no, I would like to have withdrawal bleeding. I will be happy if I get menstruation. I will feel young. Then we can give her just a luteal phase of progesterone, like luteal phase progesterone. Let her get her bleeding. And then again, you start her on estrogen plus later on progesterone.
Agreed.
Yes. So the basic thing is we start with low dose first.
Yes, yes.
And so there are various preparations available with low dose therapy, ultra low therapy, and the routine therapy where we give the conjugated equine estrogen about 0.6 to 85 milligram. There is a tablet available. So this is the way. If there is no uterus, we give a continuous estrogen therapy can be given, or a continuous combined therapy can be given. And if there is estrogen, we have to have a sequential therapy where we add progesterone from the day 7 or from the day 14.
14.
These are the preparations available for perimenopausal and in a patient who is having a premature ovarian insufficiency, where 10 milligram of dydrogesterone is added in the estrogen along with the estrogen. While in postmenopause, we reduce the dose of dydrogesterone and make it 5 milligram. Anything else you want to add?
Ma'am, I had just one comment that in this patient, if we don't directly go to menopausal hormonal therapy, and if we try maybe escitalopram or pregabalin, because her predominant symptom is vasomotor symptoms with no other issues, no irregular bleeding, nothing, correct?
Yes, we can.
So that could just, my suggestion is that by the time you're getting the workup done, because it takes time for all these things to come back, sometimes patients are reluctant to it, that this could be one option. The second thing is whether a woman wants to or does not want to have the periods. I think that we have to ask the patient for their choice. So I get both kinds of patients. There are some patients, the gynecologist told her, "Abhi tum 42 ki hogi, period ka kya zarurat hai?" She was horrified and she wanted to have her periods because it made her feel good. While on the other hand, there may be women who don't want to have periods. So I think taking the patient's choice in consideration also is important.
And age, how does the age matter? Whenever we start for vasomotor symptom, how does age play into come into action?
I don't think age is anything to do with it. I didn't understand the question. Maybe I'm missing it.
No. So whenever we start any
more than 60 years. Got it.
Yes.
Yeah. So can I talk there?
If she's less, correct. If she's less than 50, HRT has to be, should be offered, because the risk is, the benefits outweigh far more than the risk. If she's between the age of 50, the benefits of almost equal than the risks, but HRT should be offered. But if she's more than 60 years of age, I think it should be personalized treatment should be given. Do you agree with me, Tejal? Or do you still want to see the alternative therapy?
Vasomotor symptoms are going to happen early in menopause.
Yeah.
So she will be a relatively young patient, like 50 and 51 and 55. Usually the vasomotor symptoms are going to go down. They will be there, but they will not be so much significant when she's elderly.
What therapy?
Yeah.
Okay.
But that's not always true. And some women do have even 10 to 15 years after. Only thing, ma'am, what we should add here is not only is it the absolute age, but the years since menopause. So more than 10 years post menopause, it's not recommended to give HRT as the first choice.
Okay. So let's go any other alternative. I think you said that you have not covered SERMs. So let's go to SERMs and the action of SERMs. Anything you want to add, Bharti, about SERMs or Dr. Ashwini? The surface estrogen receptor modulators?
Yeah.
Or selective estrogen receptor.
We were talking about Tibelon. So Tibolon.
Well, Tibolon is not a term. Tibolon is not a term.
No, it's
No,
not.
I've just remembered that Dr. Tejal was saying about Tibolon. So Tibolon.
We are coming to Tibolon, madam.
We have to go.
In the next slide, we'll be coming to Tibolon.
After 1 year of menopause. We cannot give in perimenopausal age.
No. Tibolon will cover up later in the later
Okay, you are taking that. Okay.
Yeah. So in alternative therapy for vasomotor symptoms, as Dr. Tejal has been very specific about, we can try SERMs. These are tamoxifen, raloxifene, and they have specific action, agonist action on breast and endometrium. They have antagonist action, while on lipids and bones, they have agonist action, as compared to estradiol, which has got agonist action on all. So basically, these are the SERMs will save us from the breast cancer and endometrial cancer. So they can be tried. Well,
tamoxifen we do not try for.
No, tamoxifen is basically for osteoporosis.
Oncosurgeons and oncologists will give. But
yes,
we do get lot of women who are cancer survivors. They are on tamoxifen for a long time.
Bazidoxifin we can try. Bazidoxifin has been tried for vasomotor symptoms also. And this is an alternative therapy which we can try, bazodoxifin, and as she said, the serotonin reuptake inhibitors, then gabapentin, paroxetine. Incidentally, paroxetine is the only one which has been approved by FDA. Clonidine can be tried, phytoestrogens can be tried like isoflavones and soya and red clover, etc. Vitamins, herbal remedies, and reflexology, all these can be tried.
Surekha, can you go back to the first slide which you started?
Which one?
The SERMs. Just wanted to go. This. So just I wanted to give my experience that tamoxifen. We see a lot of patients who are by breast cancer survivors who have been started on tamoxifen by the oncosurgeons or oncologists, and they do come with thick endometrium, spotting and bleeding. And that is the reason why then ultimately we do DNC histoscopy, we send the material, and it usually is hyperplasia, or then the oncosurgeon will say that please go ahead with hysterectomy even with BSO, because then they don't want that hormone effect to be there. So tamoxifen, as it is not for us to give for treatment of menopause.
No, it's just
raloxifene. In fact,
don't give tamoxifen, madam.
Surekha, please listen to me. If you give raloxifene, it will aggravate vasomotor symptoms. So raloxifene again is not this drug to be given for vasomotor symptoms. It can be given to prevent osteoporosis. This is a good tablet to prevent bone problem.
Have you tried bazidoxifene?
No, I have not tried bazidoxifene, but here even because you have put it this osmimefene, it is a very good tablet for dyspareunia. Somebody had asked question about dyspareunia when Dr. Tejal was talking. So this is in the pipeline. India is going to get this tablet now. I don't know when the company will come out with the tablet, but if this comes out for dyspareunia, for urogenital problems, this is a good choice for us. So though it is not for vasomotor, you are asking us in relation to vasomotor, but I
agree.
That
I was just covering up terms, madam.
We can
not specifically for
other
that.
uses also. So this is
okay.
uses for the genitourinary problem.
Yes, we are coming to that case also. It will be the next case. We are covering up those cases. So this is some alternative therapy, and coming to progestins. These are the various progestins as Tejal has already told us. And this is a short note on tibolone, which has not been tried for vasomotor symptoms again. So the gold standard was estrogen and progesterone therapy. So
not only Surekha, because tibolone, no, we have to start only after 1 year of menopause. And usually the
cannot be given in perimenopausal age.
In perimenopause.
Absolutely.
Before even she gets the menopause, she will have vasomotor symptoms.
Agreed. Yes, true. So no MST, do you agree with this? No MST after 70 years? In premature ovarian failure, we give more dose of conjugated equinoestrogen. Transdermal estriol also has to be given in more dosage, or 10 milligrams of ethinyl estradiol. All these things can be tried. Do you have anything to add, madam?
Ma'am, 60 years. No MHT after 60.
No MHT after 60 years?
60 years.
60. The Endocrine Society guidelines, not after 60 and not more than 10 years post-menopause.
Post-menopausal, absolutely.
Okay. So what are the contraindications and indications for MHD? Absolute contraindications and relative contraindications. I think, Tejal, you have already covered this in contraindications. And I mean, we can see here that absolute is any existing estrogen-dependent tumor, CA breast, endometrium, undiagnosed abnormal genital bleeding, history of VT, stroke, coronary heart disease, acute liver or gallbladder disease, and relative contraindication is persistent fibroids, history of benign breast disease, chronic liver disease, and migraine. And anything else you want to add, Tejal? We can go to the next slide.
Hypertriglyceridemia. So if the triglycerides are very high now, sometimes hormonal therapy will worsen that hypertriglyceridemia. So that's one thing when you do a routine lipid profile, you can pick it up.
Okay. Okay, so what are the benefits of the MHD and the risks with MHD? So I have narrated all these things. It reduces the vasomotor symptoms, reduces osteoporosis, osteoarthritis, CVD. It reduces the cardiovascular disease risk, reduces the risk of type 2 diabetes, reduces abdominal obesity, cognitive impairment, all these things. Anything else you want to add, benefits and risks? Dr. Ashwini, madam?
You have covered it very well, and definitely, especially we have to think about bone health and cardiovascular problems.
Yeah.
If in time, it will protect from osteopenia, osteoporosis, and even cardiovascular diseases. So we have to give in time, because why everybody is saying it's 10 years, it is a window of opportunity.
Window of opportunity, yes. Yeah. So we have to take benefit of that.
Time, it will be very useful.
Yes. So we have to make use of that window and take an opportunity. So, okay. So here again, less favorable for more than 60 years of benefit and risk profile. Right woman, right age and right dose, right route. All these things should be considered when we give the MHD.
And
so
one more thing for the right
case.
duration. So Rekha, one more thing for the right duration.
Right?
Duration.
Yes, depend. Okay, so how long will you like to give it?
So the minimum time.
How long do you want to give it?
See, you can give
Bharati?
it. Yeah. See, once you start with the lowest possible dose, you can continue it for 4 to 5 years, but monitoring has to be there. That's very important. And you can try, if she's feeling very good, you can try stopping in between for 1 or 2 months and see whether the symptoms are coming back. If the symptoms are not coming back, then you can gradually taper it, and you can slowly stop it over the period for maybe 3 to 4 years, depending on how the patient responds.
Anything else you want to add, Dr. Ashwini?
How long to give? Usually, it depends. It's not that we have to give for 5 years. We have to give for 6 months,
yes, exactly.
1 year. And suppose the patient also says that now I'm absolutely fine, why continue? But we know that if when she discontinues again, she will have a problem. So we have to give it in a tapering fashion. Maybe we can make the dose less, and then ultimately we can.
How long? Exactly. Yes.
And how long will also depend on the patient to patient.
Yeah,
how long
absolutely.
will depend on many factors.
Exactly. So, madam, I want to add one more point here. Do you always take a consent before starting MHD?
Yes.
And is it advisable?
Yes.
So consent has to be taken, explained to the patient in her language, whatever she understands, and she should be explained the side effects and the risks. So before all of us, before starting MHD, please take the consent. So this is the second case. This is again with vasomotor symptoms. She's a known case of diabetes, which is well controlled. Her HbA1c is 6.9%, and she has a family history. Her mother had a venous thromboembolism at the age of 55 years following a serious accident. Now, how will you proceed with this patient who is a known diabetic? Tejal, do you want to say something?
So in this person, I would be concerned about only the cardiovascular risk profile. So what I would do is I would do a QRIS 3 score and compute that risk. And if it is high, then I would not consider MHT. But if the risk is low, then in a well-controlled diabetes, normal blood pressure, no other issues, I would not worry so much about the venous thromboembolism, because the mother had a specific event which precipitated the VTE. I would probably not be so worried. And maybe, as you have already put in your investigation, just do a screening for any adverse risk factor for VT and then proceed. From the diabetes perspective, mainly a CV risk calculation would be very important.
So one more thing I wanted to ask Tejal was, if the patient is an insulin dependent,
Okay.
treatment change. Well controlled, but she's insulin dependent.
Same way you'll proceed.
Yeah, it will not make any difference. It will basically be the degree of diabetes control. But the problem is, if it's an insulin dependent diabetes who's type 1 diabetes, then at this time she would have had diabetes for almost 20-30 years. Her CV risk will usually be high. If it's a routine type 2 diabetes and within 5 years of their diabetes they've gone on to insulin, then probably the CV risk may not be that high. So that, again, doing a CV risk score, computing it, looking at the risk fracture prediction, and then deciding would be the best way to go.
Tejal, can I ask you one question?
Yes, ma'am, please.
Yeah, in this case, would you consider non-hormonal therapy rather than going with type 1 diabetes? And in this case, would you prefer a non-hormonal replacement therapy, or you would go for a routine estrogen progesterone?
So I always think of adding non-hormonal therapy first, because yes, adding menopausal hormonal therapy is messy. And if you're able to get vasomotor symptoms under control with a non-hormonal therapy, it's a win-win for everybody. Yes. You also have more peace of mind, and patient also is more peace of mind. However, of course, if it doesn't work, then in a well-managed type 2 diabetes, only 2 years, no other significant comorbidities, very low CV risk, I wouldn't worry. And I know that we're going to give it for a short period, maybe 6 months to 1 year, maximum 2 years. I don't think it should be a major issue.
Agreed.
So does estrogen protect us from diabetes?
Yes, it does actually.
Yes. So there was a study, this is a TAPIC study, which says that those who had this premature ovarian insufficiency, they had a 32% higher risk of developing type 2 diabetes. Those with menopausal age of less than, like between 40 to 45, they had 20% higher risk, while women who underwent a surgical menopause exhibited almost 57% higher risk of diabetes. Okay. So basically this patient is a diabetic, well controlled, so MHT can be considered. And venous thromboembolism is, though it's the most important adverse effect of oral estrogen, a careful study and assessment should be done. And so we all can see this was a family history. So this was, the spontaneous venous thromboembolism indicated. I mean, there was no underlying genetic predisposition in this woman. The mother had a VT history. So that was circumstantially provoked. So probably it appears that it has been a case of, we can not consider VT as a contraindication here in this case, as Tejal has rightly said. So let's go. So what is the treatment, Tejal, for this patient? What will you give again? MHT, sequential, continuous, low dose estradiol.
I'm sorry, she was 48 years old. Was she already menstruating? She was still menstruating?
Yes, I think so.
So even I forgot whether she was menstruating or not. I'm so sorry.
No, that's okay. This patient was...
one more slide ahead, ma'am. Piche or it.
Yes. So last menstrual period was
2 years ago.
Yeah, 2 years
so
ago.
Then most of the time, somebody who's had the last menstrual period 2 years ago definitely would not be interested in her menses. But of course, I would ask the patient, and then I would go for a continuous combined so that she doesn't have any breakthrough bleeding.
Okay. So can we go to the next case? Anything you want to add, Dr. Ashwini? You want to say something?
You said she had irregular periods, no? She's not menopausal. She's
No, she's a postmenopausal woman.
Ma'am, this is a different case, and 2 years ago she had a last period.
Okay.
So can we go to the next slide? Next case?
Yes.
Okay. Now this is a patient who is postmenopausal again. 1 minute, I think.
Yeah, this is the next case.
Yes, she is a case who is 40 years old and who has undergone a surgical menopause because she has undergone a hysterectomy with bilateral salpingo-oophorectomy for fibroids and endometriosis 5 months back. She has developed acute vasomotor symptoms, hot flashes, and night sweats. She is tired of her situation, and basically, what is the MHT you will give?
See, in this case, because there is also endometriosis, then we are sometimes worried that because of estrogen, whether all the problems can aggravate, especially of endometriosis. But in this year, I think we can try Tibelon.
Absolutely. I mean, I agree with you. Basically, how surgical menopause is a problem because there are acute and sudden severe, there is acute and sudden severe onset of menopausal symptoms. There is increased risk of osteoporosis in these cases, sexual dysfunction and loss of fertility. They are depressed. So yes. So what is the treatment? What is the MHT given? As you rightly said, madam, we have to be very careful with estrogen because a part of the disease, like unopposed estrogen, may stimulate the remnant pathology of endometriosis, and adenocarcinoma cases have been noted and reported in patients with pelvic endometriosis. So we should not give any unopposed estrogen. We have to start progesterone along with it. Dydrogesterone and micronized progesterone are both effective in reducing endometriosis related symptoms. And yes, as you rightly said, madam, Tibolone can be tried. So if she is a hysterectomized patient, yes, estrogen alone. But in this case, especially with endometriosis, we have to be cautious. We have to add progesterone.
Hysterectomized?
Yes, here, like in short, like the women who have uterus intact, we can give estrogen progesterone. Those who have uterus removed, we need not add, we can, in these cases, we can, I mean, especially like this patient who has undergone a hysterectomy, we can give unopposed estrogen, but since this patient had endometriosis, we should give progesterone, add progesterone. Similarly, in the case where we do an ablation, endometrial ablation, because a part of the endometrium may remain and only estrogen may, provoke the incidence of adenocarcinoma. So let's go to the next case. She is a case of vulvovaginitis, 51-year-old, postmenopausal since 4 years, and she has vaginal dryness, local irritation. And she has been knowing this, but she has not come out of with the symptoms and she has not visited any doctor. So what will you do and how will you approach?
Can I take that?
Yeah, sure.
Yeah,
Anybody?
she is postmenopausal for 4 years and her presenting symptoms are local dryness, irritation, and urinary incontinence. So, like, she doesn't have any vasomotor symptoms, nor she complains of hot flushes or weakness or whatever. So, in this case, after ruling out her basic blood tests and ruling out her sugar and diabetes and lipid profile, liver, kidney functions, I would a urine infection also to rule out. And you do a pervaginal examination if she allows, and you see if there is another cause for urinary incontinence, whether there are any things which would require surgical interference. Otherwise, I would go ahead with local application of local estrogen creams along with, immediately I would not start with hormone therapy with estrogen progesterone. I would go for local applications with isoflavons and a lot of fluids. That way, after treating her local infection and looking out for local causes, if at all they require any surgery. And then later on, we see how she responds, and then maybe I'll start her with hormone therapy, oral estrogen progesterone, low dose.
So basically, you will give the vaginal preparation of conjugated estrogen creams?
Yeah.
Or estriol. Estriol is better in this case.
Estriol is better
compared to conjugated estrogen.
Yeah, along with lubricants and all that. Okay.
Yeah.
Okay. So how long will
this therapy, vaginal therapy, we can give her without adding progesterone orally.
Yeah.
Even till 1 year of age. And if you are giving only till 1 year, there is even no need to do her sonography, etc. Because it is just locally acting.
So,
So
how
it is
long
quite
should
safe to give till 1 year, but
Yes.
unofficially, so many gynecologists will vouch that they have given for years together. In maybe just then alternate date, tell the woman to apply the cream, or then twice a week to apply. So in this tapering manner, or just stop for some maybe 6 months, and again if she comes back with repeated infection and problems, then again you can start vaginal cream. So it is quite safe to use this vaginal estriol or conjugated estrogen creams, and there is no need to give oral progesterone. But
Yes.
if she comes with vasomotor symptoms, only vaginal cream may not be sufficient. So in these cases, we have to give oral hormone therapy plus local estrogen therapy. So even we have to be open for that much. If she's complaining of both vasomotor symptoms as well as the local vaginal symptoms, then it will be oral estrogen plus progesterone therapy plus local estrogen therapy.
So these are the common symptoms and signs which we see when the patient comes to us with genitourinary syndrome. Or the vulvovaginal atrophy is normally, this is a terminology which is replaced by genitourinary syndrome of menopause. So as you all see that they come with dryness, decreased lubrication, discomfort, pain during sexual activity, postcoital bleeding, irritation, burning, and problem by passing dysuria, urinary frequency. They have decreased moisture on examination, pallor, sometimes petechial hemorrhages, the vagina is dry, sometimes there is a eversion of the external urinary meatus. All these things we see. So what is the treatment? As you all rightly said, it is a local application which is actually there are estriol tablets also available abroad, and estriol rings are also available which can be inserted in vagina, and there is no need to keep applying it locally every day or every twice a week or so.
We can also
we
use
have to-
DHEA cream locally, but in India it is not available. Abroad,
not
the
available,
DHEA
yes.
cream is also used locally.
Yes, absolutely.
Can I just ask one question?
Sure.
Why would you use phytoestrogens for local vaginal dryness? Is there any role whatsoever?
No.
No,
No.
right?
Who said? No,
I'm
not
just
at
asking.
all. There are no local preparations available.
No, there are phytoestrogen
Are they?
local cream available.
Are
No.
they?
So in women who refuse to use any hormonal therapy like estriol cream or CE cream, then if you want, just maybe it's a placebo effect, you can
Exactly.
use the vaginal phytoestrogen cream. It
Got
is
it.
Are
available
they
in
available?
India.
I had no idea. Okay. Thank you. So let's go to the next case. This is a case, 44-year-old woman. She is presenting with postmenopausal amenorrhea for 12 months. And again, vasomotor symptoms, but she has a history of deep vein thrombosis during her last pregnancy. Her BP is normal, pelvic breast examination, both are normal. So which MHT will you choose for the treatment of hot flashes here? Because she is a case of deep vein thrombosis, old case of deep vein thrombosis. Yes, Bharati, you want to take it? Dr. Ashwini, you can say something.
No, again here I'm thinking
Yes,
you have not told us about her menstrual history. No, amenorrhea
And she
for
had
12
amenorrhea
months.
for
Okay.
12 months.
So here we can try Tibelon for whatever birth it is. Tibelon may not have very good effect on the vasomotor symptoms, but then estrogen we cannot give.
Why can't we give the non-hormonal options? So if she has amenorrhea since 1 year, we can try pregabalin, we can try escitalopram. Because are there really any studies about tibolone on vasomotor symptoms, whether they're effective or not? I'm really just asking. I don't know.
It can be used, but what you are saying is right, that other drugs which are non-hormonal
And which
can
are
be
proven to benefit. And they are
over
proven
this.
to be of benefit in vasomotor symptoms. So there's proven data with paroxetine, especially, which is
Yes.
So then I think because see, sometimes what happens, we don't have any answer to give the patient. So हम कुछ तो लिख देते हैं कि you just want to get that patient out, and this is I'm talking about myself as well, right? Sometimes you don't have an answer for the patient, like kuch bhi likh ke you just send that patient. So just because tibolone is there doesn't mean that we give it to everybody. We must start thinking about other alternatives which we can use, because at the end of the day the patient has to get relief.
Madam, and venous thromboembolic disease is a relative contraindication. Can you start MHT in these cases with caution? Yes, Tejal?
Yeah, I would
You would
err on
not.
the side of not giving, because then the venous thromboembolism, especially the cerebral venous thromboembolism, can be catastrophic. So I would definitely try all other non-hormonal options first, and only then maybe go for this.
Okay. What about transdermal estrogen therapy?
You can try, but only
You can
again
do.
issue it availability in India, difficulty of keeping it on. It usually tends to come off. So those are the few
Because of
challenges.
temperatures. Because of the temperatures.
Okay. And the risk of VT increases with age. So I mean, the older is the patient, better not to give MST at all. So let's go to the next case. She is a
Rekha,
case.
Dr. Sarita has joined. So,
Hello everyone,
Dr.
and thank you
Sarita.
for inviting me.
Good evening, Sarita.
Good evening, and thank you for inviting me.
Yeah, you are welcome. Thank you. We were waiting for you. Thank you so much for
Yeah,
joining.
we have another
We
parallel program.
we have already finished 5 cases along with venous thromboembolism. Now we are going to the next case. She is a case who has a lot of vasomotor symptoms, and she has refused any hormone replacement therapy or MHT. So how will you manage?
So I think for this patient, we have to sit and discuss the options, and the non-hormonal options would come first. And sometimes we give simple things like we counsel them about avoiding triggers. We give them vitamin E, we give them soya isoflavones, and we wait for some time. If that doesn't work, then the next option is to offer them hormone therapy. And if they are not willing for that, then our options are tibolone, as you have rightly put up, is an option.
So this is a synthetic steroid with selectivity. It is a steer, that selective tissue estrogen activity regulator, which regulates the estrogenic activity in tissue selective manner. It has estrogenic and progesterogenic and androgenic properties, and it is also very good, especially to improve the sexual activity in the menopausal woman. The dosage is about 1.5 to 2.5 milligrams per day. So how do we approach in this case? What are the indications for tibolone? I have given it already. If you want to add anything, please go ahead.
Can I ask a question?
Pardon?
Can I ask a question?
Sure.
So as I have no experience with tibolone, so because it is androgenic activity, does it increase the hirsutism or acne or hair
Not
loss?
really.
Okay.
No,
It can
Tejal.
cause a little weight gain,
Okay.
but hirsutism and all that we have never noticed in tibolone.
Okay.
No,
Okay. I'm just asking for my knowledge.
Activity is not very remarkable, I would say. Yeah.
See,
Anything else?
that is why tibolone is given in postmenopausal women. For this,
It is,
it
yeah,
not
as
good.
I have said here,
For
that it
this
is
reason, it's
indicated
given
12 months,
postmenopausal
as
women.
Dr. Ashwini has said,
Yeah.
that it should be given only after 1 year of menopause and not in a perimenopausal age group.
Yeah, because it has that little androgenic activity which is required after the 1 year of postmenopause, which keeps you, the libido and the sexual urge and everything active. So tibolone is the right drug, rather.
But it does not appear to be associated with the adverse effect on mammogenic density. Here I wanted to add one point. Those patients who are on MHT and those who are undergoing a mammographic test, do you advise the MHT to be stopped about 2 to 3 weeks prior to undergoing a mammography?
No.
You do, because it decreases the, basically the breasts are very dense, and the effect is much better if you stop the MHT to get a proper diagnosis. You should not miss any tumor. So it is advisable to stop the MHT at least for 15 days prior to our mammography test.
Because it will increase the density, right? That is what
Yes,
I
it does
understand.
increase. Yes.
Estrogen therapy will increase
Yes.
the density.
Yes.
It's a very good point, ma'am, which we actually
Yes.
often forget in practice.
Yes, absolutely. So it should be used with caution in women who are more than 60, should not be used who have strong risk factors. Please mute your device, please. So those who have tibolone also should not be used when patient has a history of stroke. Let's go to the next case. This is the 7th case. She is 37-year-old and she is the case who has undergone, she is the case of basically POI or premature ovarian insufficiency. She has moderate to severe vasomotor symptoms, and she has presented with amenorrhea for 6 months. She's having bad mood swings. Her quality of life is impacted. She wants her life back on track with regular cycles, devoid of symptoms. So what will you do? How will you proceed?
It's not even a question.
Pardon?
It's not even a question, right? Unequivocally, she has to get hormones until she reaches the normal age of menopause.
It goes without saying she's a premature ovarian failure.
Premature menopause, or also basically it's the oligo or amenorrhea for at least 4 months. She has to be less than 40 years of age and elevated FSH levels. These are the diagnostic things.
Yeah.
So what is the etiology? There are various factors with spontaneous POI. Idiopathic, it could be genetic, Turner syndrome, trisomy X, fragile X permutation, galactosemia, autoimmune, so many things. They are rattled here.
Sawyer syndrome.
Induced is, pardon? Fanconi syndrome, Bloom syndrome, and autoimmune disorders, infections, mumps, like we have mumps, orchiditis, we have mumps, ophoritis also, tuberculosis, malaria, cytomegalovirus, varicella, shigella, and so on. And induced in cases when she is radiation induced ovaries, environmental toxins, and pelvic vessel embolization. All these things can be the etiology. In this case, there are 6M. What are the sequelae of POI? Anybody else would like to add anything? Please let me know. Do you get cases of POI?
Yes, ma'am. Yeah. So many as young as 24, 26. Unfortunately, most of the time there's no reason. So we try very hard to see if there's any other reason, but most of the time none of these etiologies fit, and it's just a spontaneous primary ovarian insufficiency. In the very young people, it's very difficult. To explain to the patient. Often they're not even married or just married, and then they discover after that this is the problem. The only thing I want to say is they need absolutely regular hormonal therapy at least until the normal age of menopause, and I think 90% of them are not getting it. This usually happens
in our I would add one more thing here, Tejal. In our country, you said premature failure, unmarried girls or just married girls come. So
right.
Tuberculosis is very important in our country, and tuberculosis ophoritis is very, very not very often seen, but that you have to keep at the back of your mind. And of course, autoimmune ophoritis also has to be kept at the back of your mind.
Yeah. Just Dr. Surekha, I want to say this, that what is the problem with hormonal therapy in premature menopause women is that it's not the gynecologists and the endocrinologists who are not doing their job. But most of the time what happens, they go to another doctor. So my same relative who I was talking to, she went to a dentist and she had some pigmentation on the tongue. So the dentist asked her, are you taking hormones? So she said, yes. So he said, you should stop taking the hormones because you will get cancer. Then she goes to the oncologist. Again, she's young, less than 40, premature menopause, no risk factors. The oncologist tells her the same thing. Don't take the hormones. It's not good for you. So the problem is going against the tide and communicating to people that there's a difference between a premature ovarian insufficiency, where a woman has lost estrogen at an inappropriate time, and then a menopausal woman who ideally is supposed to not have much estrogen anymore, but we are supporting her because of the symptoms. So this differentiation is extremely challenging and is the other fraternity which is, most of the time dissuading the people from taking the treatment.
And these are the sequelae which we have in premature menopause. Basically, everything is affected. Her fertility is reduced. What I have depicted here as 6 M's. Her maternity, her mortality, morbidity is affected. She has her micturition or genitourinary symptoms. She has a poor quality of life because of severe mood swings. Her cardiometabolic effect will have her. She will be at an increased risk of cardiovascular disease. And of course, she has a reduced, more like what we call as, mechanical factor as M, where we have fracture incidence increased in premature ovarian failure. So what are the MHT formulations we give for these patients? Hormonal therapy, non-hormonal therapy, as you rightly said, and complementary therapy.
Hormonal therapy.
Okay. We can also give her antidepressants and anti-epileptics and tricyclic antidepressants.
No, ma'am. In this case, it's only hormonal therapy.
Hormonal therapy.
Hormonal therapy.
Nothing
I agree.
else.
Fully agree with you. Absolutely.
Only thing I
Okay.
would like to say
When do you
here
give?
is that we
What are the
can give
indications?
her,
Pardon?
Surekha, we can give her oral contraceptive
Yeah.
pills also. Not for this, for family planning or etc. But
Yeah.
because we are thinking, no, that whether we can give some any other type of therapy. So OCs also, because she's just 37-year-old and 38-year-old patients, we can give her oral contraceptive pills also. Low dose oral contraceptive pills with
drosperinol.
With drosperinol can be given. Yes, yes.
Okay, okay.
So we don't usually give combined OC pills in these patients is because they will be without any estrogen for 7 days to 10 days every cycle. So that is why ideally it is recommended that we give like a sequential therapy. Estrogen is on throughout and then an episodic progesterone. The reason the COC pills is not the first choice because the woman will spend 7 to 10 days every month without any estrogen.
Tejal, we have something like 24+4 regime, you know, with drosperinol. So it is only the 4 days she's not with the estrogen.
I also think that they are, you know, for younger girls, they accept oral contraceptive pills very easily. You know, whereas menopause hormone therapy is not so acceptable to them.
साहब अभी हिंदी का लेके आ जल्दी.
Hello, please everybody, can you mute your device? So what are the indications for the transdermal hormonal therapy? We have given it here, individual preference if she refuses to take any oral therapy. But of course, there is a poor symptom control.
The house of a damn Buddha.
This is the problem with webinars. I think we don't enjoy the, you know, the discussions. Give me a mute. Okay, so we have this slide showing the indications for the transdermal therapy. When the BMI is more, when she has a previous history of ET, when she has poor but they have individual preference if you want to start a transdermal therapy or not. Patient with migraine, patient with blood pressure, variable blood control, and anything else, hepatic disease and gallbladder disease and so on. Anything else, Dr. Sarita? Do you want to add anything else?
So basically the advantage is because it doesn't have to go through the first hepatic bypass and directly it gets absorbed. So all
that's the reason why.
Yeah,
correct.
Yeah, in short.
It's not moving the slide.
Just try clicking on the slide.
Yes. So these are the few preparations available in India. Tibolone also is available. Estradiol. Abbott has come out with Estrabate. And oral progesterone preparations for related symptoms. Dr. Tejal, do you want to add anything in this?
No, ma'am. Just give everybody estrogen and progesterone until they're 45 or 47, please. That's my only request.
So basically, adding progesterone, it should be a natural or neutral progesterone, and we prefer dihydrogesterone and micronized progesterone. These are the preparations. I have gone through this slide before in perimenopausal and POI cases. We add more of dihydrogesterone. In post-menopause, we add less amount. Well, this is the last case, which is a case with fracture. Basically, she is an old patient, 64-year-old. She had her LMP or menopause for 14 years. She is also having some mood swings with which is impacting her relationships, but not much. She has a sedentary lifestyle. She is feeling tired, gaining weight, BMI is 29. She had history of collision fracture 2 years back. Her uterus is intact. No other significant family or personal history like smoking, ovarian drilling, oophorectomy, pelvic radiation, or chemotherapy. How will you proceed with this patient? So she is probably a case of osteoporosis. How will you proceed with it?
First.
one ma'am, she's more than 60. It's already more than 10 years post menopause.
Yes.
So probably we will look at non-hormonal options first. And the second thing is, if there is osteoporosis, then the treatment of choice is not hormonal therapy. Again, it's good anti-osteoporosis treatment. So we'd probably do a BMD DEXA scan, quantify the osteoporosis, look at the severity, and then decide the anti-osteoporosis drug separately. And then for the mood swings and everything, we can consider maybe escitalopram, pregabalin, or something like that.
Have you used
Tibolone, no comments
raloxifene?
because I don't know.
Raloxifene and all that terms you have not used.
No, so I'm talking about
What
the
about
osteoporosis. So let me just complete. The thing is that in most of these women, we are doing them an under service if we are going to give them SERMs for the management of osteoporosis. Uh, SERMs and other medications are only recommended if the other anti-osteoporosis medicines are contraindicated. So this is one of the commonest mistakes that we see. Even orthopedicians are giving them decadurabolin, and people are giving them all sorts of things, tibolone, and these things are all favorites. But if it is osteoporosis, the woman has had a fracture, you are doing a disservice to her if you do not give her proper osteoporosis treatment. SERMs is not a substitute for anti-osteoporosis treatment. It can only be considered if all the other anti-osteoporosis medications are contraindicated. I hope this point is really clear, because we are all going to be at that age at one time, and we don't want others to take the wrong decision.
So have
Teja,
you
my
tried
question is,
bisphos-
as you rightly said, non-hormonal therapy, but biphosphonates, if required, can we
bisphosphonates?
add at this age?
Of course. Bisphosphonates you can add at any age. There is no age criteria for bisphosphonates. You would look at maybe the creatinine and heart problems, but that, but those are minor issues.
Another thing I want to add, the monoclonal antibodies,
denosumab.
They work very well, in though it's a very costly medication, but it works very well for osteoporosis.
Yeah, but the problem with denosumab is there is no endpoint of denosumab. So it has to be continued to be given. So if you want to go choice wise, if the T-score is not as bad as -3, then bisphosphonates will be first. If the T-score is very bad, we'll go for teriparatide. The only issue with denosumab is it has to be continued until further notice. If you stop, the risk of fracture goes up.
What is the role of parathyroid hormone?
Yeah, teriparatide we use. So if the osteoporosis is very severe, then we'll start with teriparatide actually. So teriparatide is the parathyroid hormone which we give. So bisphosphonates, oral or IV, teriparatide. The only problem with teriparatide, again, Dr. Sureka, is that it's an injectable therapy for 2 years and it's a daily injection. So that is one of the obstacles for teriparatide therapy. Denosumab is also excellent, but the problem with denosumab is there is no stop date. So the patient has to keep on taking and taking and taking. The advantage of IV bisphosphonates is you give for 3 years and then you give the patient a break and the medicine carries through for another 3 to 5 years.
So we are almost coming to the end of the discussion. These are the recommendations from the Indian Menopause Society. I think Dr. Ashwini will be able to highlight it better. If we have missed anything, please Dr. Ashwini, Dr. Tejal, Dr. Bharti, Dr. Sarita, please add anything if I have missed anything in this whole program.
Baba. Those who are interested,
hello, please mute your device.
Hello, go on the IMS website, and all the recommendations can be seen there, and then they can go through, because very nicely they have been written and.
Yeah. I think now we have really very clear guidelines. So I think that it's easy for us to practice if we go through these guidelines carefully.
Yes, Dr. Ashwini, you want to add anything? Dr. Sarita, anything else? Connection available.
Can I just add just one last point?
Sure.
Sorry.
Yes, Dr. Tejal.
It's just that I think that more and more endocrinologists and gynecologists need to work in collaboration and talk to each other. There are times when I get stuck then we talk to you, and times when you get stuck, you talk to me. But just that together we can do a lot more for women with menopause. I think at present, all of us feel that we're not doing enough. And the only way to go further with this is if we are in collaboration with each other, I think we can do a better job.
Honestly, we are very lucky to have you in Vashi, Tejal.
Yeah, I came late to menopause, but yeah.
Yeah, this is a take-home message for all of us. MHT must be individualized. Basically, it is a and tailored according to the symptoms and requirements. It should be, I mean, it should not be taken lightly. The vasomotor symptoms and all those things should be given an importance. And when the patient comes to us with these symptoms, we should not really, we should pay attention to it, and we give importance to it. So basically, the end thing is, with the one size does not fit all. It is not the same treatment which you can give to all the patients. The treatment will differ. Thank you. Thank you very much. Thank you, the participants.
Thank you, Sureka, for a lovely panel. Very nicely managed.
Thank you,
Thanks a
ma'am.
lot.
Very nicely done. And I love the cases. They covered everything.
Thank you. Thank you so much, Dr. Ashwini, Dr. Sarita. Thank you so much, Dr. Bharati, and Tejal, of course. Thank you.
Ashwini, very nice.
Thank you. Thank you for calling us, Bharti.
Sarita, good evening.
Good evening.
And Dr. Mini, I must give special thanks to her.
Yeah, thank you, Dr. Bharti. Thank you, Dr. Mini, for inviting
Thanks a lot.
us.
Thanks a lot for joining.
Yeah.
And enlightening us.
Thank you. Thank you, ma'am, for the wonderful panel discussion. With this, we come to the last session of the day. The last session of the day will be newer hormonal replacement therapies, a hope for millions of women suffering in silence. Our esteemed speaker for the session will be Dr. Sarita Bhalerao, ma'am. Actually, I've already introduced ma'am, but I will again introduce her. Ma'am is a consultant at Bridge Candy, Reliance Hospital, Saifi Hospital, Bhartiya Wadia Maternity Hospital. She is the president of MOGS. She has been a joint secretary of FOXY. She has been a chairperson of West Zone RCOG India and has assumed many such important positions across organizations. Thank you, ma'am, and over to you for the session.
Yeah, thank you. Can you hear me? Am I audible?
Yes, ma'am.
Yeah, can you see me, or is my video? Yeah, okay. So after that wonderful panel discussion, it's my pleasant duty to just sum up things. And I really feel that newer HRTs have really brought hope for many, many menopausal women. And we really have a nice basket of things that we can offer them now. So when we think of what is the right HRT, we think of the right estrogen, the right progesterone, the right dose, the right regimen, the right duration, and the right route. And yeah, one sec. Okay, yeah. So when we look at estrogen, you know, all these years we were using basically the conjugated equine estrogen. And today we have a choice. We have better estrogens, including 17-beta estradiol, which is available. Abroad, of course, there's a choice of oral and transdermal. Here in India, we have only oral. When we look at progesterone, initially we were using medroxyprogesterone acetate. Today we have a choice of micronized progesterone, dydrogesterone, and the LNG IUD. In the panel, it was beautifully brought out the role of Tibolon, and also the way of giving it, that you can give it either sequentially, which Dr. Tejal said wonderfully, that we can give estrogen every day and just supplement the progesterone for a few days in the month to protect the endometrium. Or after menopause, one can give continuous in a smaller dose of progesterone. And we have newer things like bazidoxifene and ospifemifene, which are not available in India. Now, when we look at the combination of 17-beta estradiol and dydrogesterone, why is it the natural choice? And that is because it mimics the natural hormones. And both the 17-beta estradiol is a potent human estrogen, and dydrogesterone basically is a progesterone with very good oral bioavailability and affinity for progesterone receptors. We have been giving it for years for pregnancy, and we are very familiar with it, and we know that it works very well orally. Now, here again, this shows you how to give it. And as we said earlier, that you can give either continuous sequential, every day estrogen, and then for 10 or 12 or 14 days in the month, give progesterone, which gives excellent protection to the uterus, which is very good for perimenopause and for primary ovarian, for premature ovarian insufficiency, because patients will get a withdrawal bleed. Or after menopause, when we give continuous estrogen and progesterone, it results in no bleeding in 90% of women after 12 months. But the first few months, they have to be counseled that breakthrough bleeding may occur. Yeah. So now this is a very interesting slide which says that yeah, for those who have a uterus, we must give estrogen and progesterone. For those who have had a hysterectomy, unopposed estrogen. But today we have a third category of women, and we have women who have had an endometrial ablation, and endometrial ablation and TCRE has become very popular. And that is why we must remember that these patients should also have a progesterone. Now, if they have had after natural menopause, perimenopausal sequential estrogen and progesterone to regularize bleeding and improve system, and post-menopause, we should give them continuous. Then we come to what is the right estrogen. So when our choice of estrogen, the advantages of 17-beta estradiol is that it's chemically and biologically identical to endogenous estradiol, and there's a minimal liver load as compared to estradiol valerate or as compared to conjugate equine estrogen. So like we have initially used conjugated equine estrogen, we know that there's a prothrombotic effect, and that's why all that discussion about the the WHI study and everything. But today we know that these newer estrogens we have, they are circulate in the plasma as free estradiol, there's minimal liver load, and they have many significant advantages. Okay, so let's take a look again. What about ethinyl estradiol? There was a little discussion in the panel about ethinyl estradiol, and it is a synthetic derivative. And what we know is that ethinyl estradiol has this 17-beta has better effects as compared to ethinyl estradiol. Ethinyl estradiol is what we use in the oral contraceptive pill, but when it comes to hormone therapy, we want to give a more favorable estrogen. I'm having a little, these slides are not, okay. Now we come to ethinyl estradiol is more of a risk than 17-beta estradiol. And this is because ethinyl estradiol has more risk of venous thromboembolism. Ethinyl estradiol causes more adverse effects on the liver than estradiol. So in both these ways, it results in a greater chance of VTE and stroke and cardiovascular risk, and also cholestatic hepatotoxicity. So now we come to what about the right progesterone? Now, many progesterons are available. And when you look at all progesterons, they have progesterogenic, estrogenic, androgenic, anti-androgenic, glucocorticoid effect. And here I want to show you that basically what we are looking for is a progesterone which has maximum progesterogenic effect without having other effects. And here dydrogesterone is a very good alternative. Drosperinone has anti-androgenic effects, so it's ideal when we use it in the oral contraceptive pill and for PCOD. And cyproterone acetate again has very good anti-androgenic effect. But when we look at medroxyprogesterone acetate, there are other effects, and that is a disadvantage. So post WHI study, the medroxyprogesterone acetate turned from hero to zero. And there is a general consensus that the poor cardiovascular breast results of the estrogen progesterone arm of the WHI study were not a class effect of progesterone, but because of medroxyprogesterone acetate. And this is because medroxyprogesterone acetate is a potent agonist of progesterone, androgen, and glucocorticoid receptors. MPA does not bind to the estrogen receptor, but acts as an anti-estrogen that dilutes the beneficial effect of MHT on coronary outcomes. Also, the risk of breast cancer with MHT is not more than general risk factors. Now, all patients come and sit in front of us, and we all know in practice, the first thing they'll ask is that, does it cause cancer? And even if you say, whatever you say, they're going to ask their friends and their relatives. And now we know that the risk of breast cancer is a marginal rise. It's related to the progesterone use. And therefore, with dydrogesterone, there is a lower risk. So the risk of breast cancer is not the same with all MHTs. And when we look at the risk may be lower with dydrogesterone or with micronized progesterone than with a synthetic progesterone. So today the choice of progesterone is very important. Yeah, now when we look at this study and this choice of progesterone with breast cancer risk, it shows you that here it shows very well that the risk elevation is not uniform for all progesterones, but it is lower when we use the dydrogesterone. And here again, it shows you that the type of progesterone is very, very important. This. Yeah, so micronized progesterone or dydrogesterone are linked with a lower risk of MHT-associated breast cancer than synthetic progesterone. And these large studies have now been done, European observational studies, case control studies from France and registries from Finland have all substantiated this. So when we look at VTE and stroke, as we said in the panel, that transdermal estrogen is less likely to produce VTE, stroke, and coronary artery disease. So therefore, in these patients who are at higher risk, transdermal MHT containing natural progesterones is safer. Now, the risk of thromboembolism also with different progesterones, when we looked at different progesterones, I think dydrogesterone and micronized progesterone appear to have an acceptable thrombotic profile. What about the right dose? When we look, so this combination is a very, very good, unique combination, and I've been using this in my practice for perimenopause and for primary ovarian insufficiency. 1 milligrams of 17-beta estradiol with 10 milligrams of dydrogesterone as a sequential MHT, and for postmenopausal 1 milligram plus 5 milligram dydrogesterone as continuous. And I think I've been using the sequential more often. There's been more opportunity to use that, and especially for patients who have primary ovarian insufficiency. So continuous combined estrogen plus dydrogesterone 1/5 improves the hot flashes as compared to placebo. And you can see in this that it's extremely effective for hot flashes. So even though we try non-hormonal and we try isoflavones and we try vitamin D, this giving MHT is the best solution for the hot flashes. And sequential combined estrogen plus dydrogesterone also decreases hot flashes as effective as conjugated equine estrogen or norgestrone. When we look at the cancer risk, it is the cancer risk is very comparable, and it is this use for several months to a few years was not associated with a higher risk of gynecological cancers. So what about the right regimen? So here again, with sequential estradiol and dydrogesterone, there's excellent endometrial safety and regularized bleeding pattern. That is very helpful. And when you give continuous estradiol with dydrogesterone, the safety profile is good. This study showed that the endometrium is very well protected. And though they have breakthrough bleeding initially, most of them will become amenorrheic throughout the study. Now, tibolone was very popular some years ago, and tibolone is known as the gonadomimetic because it has estrogen and androgenic and progesterogenic features. So tibolone can be given, and the difference between combined MHT and tibolone is that the MHT is very, very effective for vasomotor symptoms. It has a significant improvement in the fracture risk, the libido improves, though tibolone being androgenic will improve the libido significantly. But with combined MHT, the breast cancer risk is lower, the breakthrough bleeding is less compared to tibolone, and many, many benefits are there. So for long-term treatment, tibolone is not a great choice. For a short-term use, it can be given. Now, when we look at the lipid profiles also, oral estrogen plus dydrogesterone was found to increase mean HDL cholesterol by 7% compared with the 26% reduction in HDL cholesterol with tibolone. So HDL being the good progesterone, the MHT is better. So symptomatic benefits of tibolone appear questionable compared to those of combined HRT. More concerning is the uncertainty about tibolone's risk profile, and weight gain and bloating, increased LDL levels, and decreased HDL are also a concern with tibolone. Yeah, sequential estradiol and dydrogesterone has been studied very well, and this improves HDL levels, whereas conjugated equine estrogen and norgestrel did not. And when they looked at breast cancer risk with estrogen and dydrogesterone, it was similar to non-users of MHT. Again, estrogen with dydrogesterone is not associated with a demonstrated increased cardiovascular risk, so it is safer. And in our country, when we don't have transdermal, I think it is the, the best choice. And also sequential estrogen with dydrogesterone versus placebo was found for the bone mass. And what they found is that it significantly increased the lumbar vertebrae and the hip BMD versus the baseline. So when consider when making a right choice of HRT, the right duration, as we said in the panel, it has to be individualized. And for less than 40 years, MHT is mandatory till the natural age of menopause. And Dr. Tejal was really very emphatic in that. From 40 to 50 years, the benefits increase the risk. From 50 to 60 years, if they are still less than 10 years of menopause, the benefits increase the risk. But after the age of 60, the risk can be more. And this is where, for local symptoms, local estrogen is perhaps the best choice. So in primary ovarian insufficiency, sequential estrogen is recommended till the age of natural menopause, and it is regularized the bleeding pattern, improving the quality of life, and actually studies have shown improved life expectancy. Menopause in our women does strike earlier, and it comes at an age maybe 45 or 46. And there are so many women who suffer in silence. And I think that for us as practitioners, we have busy OPDs, but we should be a little sensitive and a little vigilant about the menopausal risks. Now, menopause, MHT started in the early perimenopausal or the early postmenopausal period is cardioprotective. But if it is begun late after menopause, more than 10 years after menopause, it increases the risk of cardiovascular disease. So early initiation of MHT has many benefits. It reduces osteoporosis. There's a reduction in CHD. There's a 30% reduction in all-cause mortality. So I think that the window of opportunity is there, and let us not miss the bus with our patients. When we look at the right route, here again, we have we can give them oral, or transdermal unfortunately is not available with us, or we can give them vaginal estrogen. But estrogen plus dydrogesterone oral is very good for vasomotor symptoms, genitourinary symptoms. And when we look at all the risks, we find that it is as effective without many risks as transdermal. So with that, I'd like to thank you all for patient hearing, and a big thank you to Dr. Mini and to Dr. Bharti More for inviting me to participate in this program.
Thank you, Dr. Sarita. That was really wonderful.
Thank you. Thank you, ma'am. Thank you so much for the wonderful talk. Any questions for ma'am? Okay. So with this, we come to the end of our session. I would like to thank all the faculty members, all the delegates for participating in our webinar today and making this program a success. I would like to thank President of MOGS, Dr. Rahul Vani, Dr. Santosh Zaibai sir, Honorary Secretary, and Treasurer Dr. Bandita Sinha. I would like to thank Abbott for providing support for today's webinar. And thank you everyone for patient hearing and your participation. I hope you all enjoyed the program today.
A big thank you to the anchor also. Did a good job.
Thank you, ma'am.